So I'm sure all of you must be aware of this octopus. And anybody who's a fan of football would know in South Africa, this octopus told that Germany is going to win the World Cup. Or this parrot. Sometimes we look at the hands and we can have a future prediction. We can look at the crystal ball. You see, this is the eternal question that I am faced every day. What are the chances of my father's survival, doctor? And now how do I make a judgment? I have to churn out a number to that patient's family. Where do I get that number from? So the coming 25 minutes I'm going to spend is how do I arrive at that magical number? Now, first of all, what to prognosticate? I'm not going to prognosticate only whether this patient is going to survive or die. I think it is not enough nowadays. We need to know, even if he survives, what will be his quality of life? Will he be able to walk? And what will be the duration of treatment? How long is he going to be in ICU? And what would be the cost of his treatment? So I think the prognostication should include all these statements. And why to prognosticate? That is another question. Sometimes a family asks me, what are the chances of survival? I ask them back, why do you want to know? If you want to support him, why do you need a number? We just need to continue treatment till he gets better. But, sometimes the families have queries. We have to give them answers. Sometimes we have to defend ourselves. In the sense, we tell the family, patient is not doing well, his chance of survival is very poor, and ultimately he doesn't do well, so we can defend ourselves. To allow family to sort out finances, withdrawing or withholding support, family to take patient home for terminal care. Resource allocation is another issue, especially in a nationalized health service system. So there are many reasons we prognosticate. Let me tell you about science of prognostication. A very crude science. You can look at the numbers of tubes, the lines at the patient's bedside and multiply it by 10, and that's mortality. Anybody having 10 syringe pumps going on, it is 100% mortality. So you see, it's very easy to prognosticate. Now let me give you a patient. 40-year-old male admitted with severe pneumonia requiring ventilatory support, blood pressure 110/70, no vasopressors, but rising urea creatinine, dropping urine output. He is 40 years. So let me have a show of hands. How many you think his chance of survival is 10%? How many you think is 30%? A few. How many you think is 50%? And how many you think is 70%? Oh, wow. So we got a lot of optimistic intensivists here. So now the same case scenario, I made the patient 75 now, and he's got severe community acquired, the same thing. Now what do you think? 10% survival, 30%? More hands, 50%? More, 70? Less. So you see, as soon as I change the age of the patient, the survival rate definitely decreased immediately, I can see in the crowd. Now, I have added diabetes and congestive heart failure to the same case. Now what do you think? 10%? 30% survival? 50? 70%? Almost none. So you see, if it looks like if this patient have comorbidity, the chance of survival comes down. And what do you think? Mortality is highest in patient admitted to ICU from home, ward, other hospital, or other hospital ICU. Well, it is intuitive, probably from other ICUs. Now, disease category. What is the disease this patient is suffering from? Malaria will have a different mortality than a meningitis patient. And, science is almost a continuous process. Now, the same patient with pneumonia, if he was treated prior to, say, activated protein C era, now we have activated protein C, which have been found to be helpful, especially in patients with pneumonia, And now if he gets activated protein C, will he benefit from activated protein C? What do you think? Yes, there are a lot of literature. So will his prognosis improve? From 70%, it might come down to 50%. So there are, in mortality prediction, there are many things which have to be taken into account. We have to take the age we have to take the comorbidity, we have to take the organ failure, the underlying disease process, what is the time to treatment, and has he coming from home, from the ward, and what are the recent advances have they been utilized in that patient. And it is very difficult in a human brain to compute all this at the bedside and talk to the family and come out with a number. And that is where the scoring systems come. And I think it is behoving on each and every one of us. We have to have some kind of a scoring system in our ICU. Now, in my rest 20 minutes, I'm going to give you overview of these systems. Now, the scoring system could be a global scoring system. We see the patient as a whole, which could be an Apache score, a SAPS, or an NPM score. We can look at the organ failure, which could be SOFA, MODS, and LODS. We can look at organ or a disease specific. All of you are aware of Glasgow Coma Scale. There are pancreatic scales. There are cardiac, ARDS scales, pneumonia. There are task-specific prognosis, like therapeutic intervention scoring for the nurses. There are population-specific scoring like APGARs and for the post-operative patient. Now, how this scoring system are developed? It is very important. If I'm using a scoring system in my ICU, I need to know from where this scoring system was developed. So what was the population of interest? So normally what happens whenever a scoring system is developed, initially you select a population. It has to be in thousands, 10,000s, 15, 20,000s of patients. You select the variables, as we mentioned, the age, the gender, the comorbidity, and then you select the time. Are you going to do this in the first hour, first 24 hours? And you select the outcome to be tested. Is it the mortality? Is the ICU mortality? Is the hospital mortality? Then you look into that patient population and see which of these variables come out as a predictive model for mortality. Apart from that, then it has to be validated in a different patient population. And then one has to assess the performance. Any scoring system that you will read, you will find these two words, discrimination and calibration. It is very important. We need to know what is the difference between these two. A discrimination of a scoring system is one which will differentiate between life and death. Whether an Apache is very good to discriminate between life and death. And calibration is whether you can discriminate at different degrees of risk. For example, in a very sick patient, an Apache might not be able to differentiate life and death, whereas in a less sick patient, it might be. And these systems need to be updated almost at a 4-yearly basis. Now, there are 4th generation Apaches which are in being now, Apache 4. There are SAPS 3 and NPM 3 models as well. Now, Apache 4 has been validated in 110,000 patients, mostly from US. Whereas if you look at SAPS 3 model, it was done in globally, 35 countries, 5 continents, but very few countries from Europe, from Asia are in SAPS 3. So if I had to use one model, probably Apache 4 and SAPS 3 might be the right model. Now, what is the utility of this prognostication model? First and foremost, we need quality control. We need a benchmark. We need to triage our patient. We need to send our patient to ICU or to SDU or to the ward, the resource allocation, prognostication, and for research purposes. Now, this is a very key slide. What is an SMR? Each and every unit, when we compare ICU, sometimes we say that my ICU is worse than the other ICU, that ICU is better than the other ICU. So how do I know? This is what is called standard mortality ratio. It's a predicted mortality and observed mortality. If I am taking care of very less sick patients, probably the mortality in my ICU will be very low. Vis-a-vis another ICU, which is taking care of very sick patients, their mortality will obviously be higher. So it has to be risk adjusted. So we need to know what is the observed mortality in my ICU, which is given depending upon the number of patients who died, and what should be the predicted mortality. In order to know the predicted mortality, we need to know a scoring system. We need to utilize any one of the scoring system and see what is my standard mortality ratio. If it is more than 1, then probably more patients are dying than they should have. It's not only mortality. Nowadays, these models can tell me the length of stay, ICU length of stay, the hospital length of stay, and duration of mechanical ventilation. And this model has come up. If you put SMRs at the x-axis and you put length of stay in the y-axis, the ICUs which are here, the less length of stay and the lower SMR, probably they are the best ICUs, because the longer is the length of stay, the more cost to the patient. So even if an ICU has a low SMR, but if they are keeping a patient longer, probably they are not cost effective. So the goal of an ICU should be to keep the SMR less than 1 and to at least have the length of stay equal or less than expected for that patient's risk. Apache scores have been used for in a lot of researches where you have to control for the patient. So both the control group and intervention group have the same Apache score. As you know, in community acquired pneumonia, there is a triaging system. You can triage the patient depending upon this curve score. And I think this is the very unique feature where a drug has been licensed depending upon a particular Apache score. That means this drug is probably not useful for less sick patients. So this drug is useful for more sick patients. Now, how do I implement? How do I implement Apache scores or scoring systems in my ICU? You know, Apache 2, it is available, but we go for Apache 4 system, which is available free. It is available free to download from internet. It is in public domain. Anyone can use Apache 4 in their own ICU. There is an Excel sheet, and the nurse just had to say what is the worst value during that time. The worst value during the first 24 hours. The worst pulse, the worst blood pressure, worst temperature, worst respiratory rate. It just puts the values here. The points will automatically come. And then there are a lot of weighted, we don't have to do anything here. We just have to tell what is the comorbidity of the patient, and then it automatically calculates the Apache score. Then we have to say what is the comorbid. We have to select the patient's diagnosis. There are a lot of diagnoses. We just have to select one, and it gives a predicted mortality of that patient. Now, we have been doing it over last 4 years. Apache 4 we have been doing for the last 2 years. You see, there is a question which is being raised every time when we have this scoring system debate, is these scoring systems are done in USA. Can this be utilized in my ICU? My answer to this is, well, my SMR of 1 might not be equal to their SMR of 1, but I can I can track my own performance. I do not care what is their SMR is. I know I have a scoring system. It might not exactly be the same validation as in the States, but at least I have a system in place. I can look at my patient's mortality and I can track my own performance over time. So I'm not comparing my SMRs to anyone else's. I can track my own performance. It looks like during this time we were not doing well. There are a lot of months where SMRs are going pretty high. It could be that we have shortage of doctors, shortage of nurses. It's very important each and every ICU has a look at their SMRs on a monthly basis and track these. And then only you'll find out the problems. And then only you can look for the solutions. Not only we look at a global SMRs, we also look at SMRs for patients who are admitted from emergency medicine services, from other hospitals, from the ward, from the step-down units, from the OR, and you will find the SMRs are pretty different, like from the other hospital. SMR is twice the mortality. So it looks like probably we are not doing very well for patients who are being transferred from outside. We also look at our SMRs on patients who are ventilated, who have non-invasive ventilation, who are on dialysis, and who get blood transfusion. As you can see, our total SMR was less than 1, but you look at these SMRs on these patients. So it looks like that, okay, we are managing our patients well who are less sick, but patients who are requiring ventilation, patients who are requiring dialysis or requiring blood transfusion, their SMR is more than 1, then probably we are not taking good care of very, very sick patients in our unit. The non-invasive ventilation, we are very surprised from our data over the last 2 years. Our SMRs for non-invasive ventilation has been very high, and that has been the scenario even in the West, where nowadays non-invasive ventilation is being used very commonly for various purposes. Yeah, and if the patient are not very strictly monitored, they come to harm. So non-invasive ventilation SMRs can also be very high. We also look at our length of stay. As you can see, this is the expected length of stay, and this is our length of stay. So if the expected length of stay was 4.6 and our mean length of stay was 4.3, we were almost there. So we were not keeping patients longer than what was required. And this is very important so far as cost is concerned. Now this is a very important slide. You don't have to go through all of this. We do a morbidity and mortality every month. We look at the patients who died in my unit. We look at their Apache scores. We look at their predicted mortality. We also look at their SAPs and their predicted mortality. For example, if you look at this number 7 patient, the predicted mortality was 7%, but this patient died in the unit. So what went wrong? So we have to go back to this patient's file. There are patients with predicted mortality of 90%, 70%, 67%, but when you have predicted mortality of 10%, 8%, and if that patient dies in the unit, one has to look at that patient's file and see exactly what happened to that patient. Now there are a lot of organ system failure scores, the MSOF, the SOFA score, and they look at different physical variables and then decide, but they do not prognosticate. They do not tell us the mortality. Now what is the Indian data? We have done some work with Apache 4. We have been doing Apache 2 initially, and what we found that on the same group of patients, if you do Apache 2, the SMR looks very good. But in the same cohort, when we start doing Apache 4, the SMR jumps. Apache 2 was validated about 14 or 15 years back. So if I'm doing Apache 2 in my unit today and I'm finding good SMRs, that means that probably I'm treating my patient well as they have been treated 15 years back in States. But Apache 4 is 2 years. 2 years back Apache 4 was validated. So if I am treating my patient with standard of care, the present standard of care, I need to do Apache 4 rather than Apache 2. So we think Apache 4, which is easily downloadable, free in public domain, should be utilized. Now sepsis. Now if I have a patient with sepsis and patient's family asks me what are his chances of survival. Now what are the data? There are data from international study, there are data from Asia region in the EPIC study, which says overall ICU mortality is around 18%. This is not severe sepsis or septic shock. This is simple sepsis patient who has been in ICU. So if you have a patient in ICU with sepsis without shock or severe sepsis, his mortality will be around 14-15%. But when we did a Google search on sepsis and India, we didn't find many studies. There's one study that we did, and we are still ongoing study, where we looked at our mortality of severe sepsis patient. The ICU mortality was 57% of severe sepsis. So 1 out of 2 patients with severe sepsis will not survive in my ICU. So it is very, very important that each ICU have their own data. So to be very honest, in order to tell honestly to the patient's family regarding the survival chances of that patient in ICU, I have to have some data. Similar kind of patients in my ICU, what happened to them? Then and then only these numbers. And their mortality and the SMR was higher in our study than other Western studies and Australia, New Zealand studies. Now there are biomarkers for prognostication. We heard about lactate. there are procalcitonins, there are CRPs. Procalcitonin is coming up as a good prognostication marker with a good sensitivity and specificity, as good as Apache, but it is very costly. Now coming back to our patient, again 75-year-old male with pneumonia, what are the chances of his survival? The patient's family asks me. I can go to the international database, I can go to my Apache database, SOFA score, look at the biomarker patient. So there are many ways. This patient that we had, 20-year-old female, malnutrition, pulmonary TB, predicted mortality was 5%. And the girl died, unfortunately, with fulminant liver failure due to anti-TB. Individual prognostication is the biggest limitation that we are facing at the present moment with any of the system. You cannot score and say that his predicted mortality and tell the family that, look, he has got 95% chance of survival. Because you see, there are a lot of things in the ICU which can go wrong and the patient might not do well. So individual prognostication is very difficult. So whenever we try to communicate with the family, we tell them that, look, in a group of, that is the best we can do. In a similar patient, the chance of survival is so much. But as regards that particular patient, it will be very difficult to change from day to day. Individual prognostication is a big problem, and I think we're still left with housing at the crystal ball. Thank you.